Perfect.
Okay. So the first part, we were just discussing what is hyponatremia, what are the different types of hyponatremia. So you can go through the first part and revise what is there. Now, today we will just concentrate on hypotonic hyponatremia because the first two parts were discussed already. So why are we so worried about this hypotonic hyponatremia? We know that's when a patient with some comorbid illness develop hyponatremia, it adds to morbidity and mortality. This more so in patients with coronary artery disease, liver disease with ascites, and other underlying diseases, intracranial bleed or other neurological problems. We also know that if you are over-aggressive, very enthusiastic in correction of hyponatremia, it can also produce what is called as an osmotic demyelination syndrome. It can also result in a severe irreversible neurological deficit. What we should understand is undercorrected hypotonic hyponatremia is less dangerous to the hyponatremia. So when there is hyponatremia, when the process is acute, to correct the ECF osmolality immediately, water has to enter the brain cells because sodium cannot come out of the brain cells. So the water enters the cells, the ECF osmolality rises, the ICF osmolality at a higher osmolality equalizes to the ICF osmolality. Now what happens is the neurons are spared, the astrocytes swell, and they develop cerebral edema. Now, as time goes, the brain senses something is wrong. It tends to normalize the osmolality by synthesizing some inorganic osmolytes and organic osmolytes, glycine, taurine, creatine, mya, and acetol. Initially, it sends sodium, potassium pumped out through the sodium-potassium ATPase system. Aquaporin channels are removed, so ADH is not able to act. More water is excreted as urine in water. So this will try to bring back the osmolality to normal. So we should understand there is a physiological adaptation happening to the osmolality by the brain and by the ECF. Without understanding this, if we rapidly correct the ECF osmolality, what will happen is the ECF osmolality immediately goes up. Now the ICF osmolality is still low. So the ICF osmolality to normalize will send water from the cells to ECF. The cells get dehydrated, so they'll be shrinking of vessels and can produce hemorrhage and also result in what is called an osmotic demyelination syndrome. So, to just diagrammatic representation of what I said already, there is a rapid adaptation by loss of sodium, potassium, and chloride. The osmolality normalizes. Slow adaptation is by loss of organic osmolytes. So it should be corrected slowly. If you correct rapidly, it results in osmotic demyelination syndrome. Am I audible?
Yes, madam, clearly.
Okay. Now, next step is for every clinical medicine, history is very, very important. So to find out the cause of this hypotonic hyponatremia, you should ask for GI symptoms like diarrhea, vomiting, loss of blood, loss of body fluids in the third space, ascites, pleural effusion, any coexisting disease, infection, malignancies, etc. The history of medication is very, very important, especially diuretics emphasizing on thiazides, antipsychotic medications, antidepressants, valproate, carbamazepine, antiepileptic drugs are commonly used, and NSAIDs which produce hyporhythmic hypoaldosteronism. All these medications can produce disturbance to the osmolality. So we should go into a detailed history. We also should take a detailed dietary history because in the last class we discussed what is the ketose syndrome or beer potomania. Because somebody takes more water with less of solutes, what will happen? There is no solute to be excreted in water. So water will be retained. that itself can produce hyponatremia. So we should take a detailed history as reference to the salt intake, the protein intake, and water intake of patients. Because in psychogenic polydipsia, patient takes around 10 to 12 liters of water. So we should only take a good history to find out anything is wrong. If the intake of water, intake of protein in the diet, how much salt the patient is taking. Okay. Now, in the hospitalized patients, things are not very fine because very often, at least when I did my house science, I never knew the difference between normal saline, half normal saline, 5% dextrose, and ringer lactate. Because they'll say give some fluid, not knowing what we are doing, used to give 5% dextrose. We never knew that all this is detrimental or disastrous to a patient because there is no way to measure electrolytes also. I did my PG way back in 81. Then only we started measuring sodium and potassium. So we didn't know all that then, but still people survived. My chief used to say that even without doing, all your patients survived. So it is not very great they are doing so meticulously and your patients are self. Not like that. But whenever something is available, we should try to put it into practice and do it correctly. Now, the first step is to find out whether this hyponatremia is mild, moderate, or severe. In mild hyponatremia, we know so anything above 135 to 142 is taken as normal. 130 to 134 is mild. 120 to 129 is moderate. Severe is less than 120. Now, if there's acute or chronic, if patient gets admitted with a documented normal sodium, it is always taken as acute. If there is no documented sodium value on admission, and if you document hyponatremia, then the duration is within 48 hours, you should accept it is chronic hyponatremia and try to correct it slowly because ODS occurs more common with chronic hyponatremia. In we said about the levels of or degree of hyponatremia, but somebody has neurological manifestations, ataxia, slurring of speech, etc. Even with sodium of 120, you should take it as severe hyponatremia. Now, what are the clinical features of hyponatremia? Hypotonic hyponatremia. The patients may be totally asymptomatic. On a routine biochemical workup, we may detect a sodium of 132 or 133. It is usually reported in 20 to 45% of hospitalized children. During monsoon, also there is a peak incidence. Humidity and temperature also play a role in development of hyponatremia. The patient can present with symptoms of associated comorbid illness, heart failure, patient may be dyspneic, patient may have a raised GVP, the patient may have a period edema. The patient have features of cirrhosis liver like ascites, or the patient may not be taking any food due to anorexia of chronic kidney disease. Hyponatremia itself can produce neurological problems like gait abnormalities. If it is severe, the patient can even go for respiratory arrest. So we should worry about the degree of hyponatremia and correlate it with symptoms of hyponatremia. There is hyponatremic hypoencephalopathy. This entity describes when there is an alteration of sensorium and seizures due to brain edema. As we earlier said, when water enters the astrocytes, the skull can accommodate only up to 10% increase in volume of brain. With more rapid increase, there can be herniation of the brain resulting in death. So we should be very careful in diagnosing hyponatremia and managing hyponatremia. What are the severe symptoms? There is an acute and marked reduction in serum concentration, can result in symptoms like seizures, obtundation, coma, brainstem herniation, and respiratory arrest. It is not very common with chronic hyponatremia because, as we earlier saw, the neurology, the brain cells get adapted. It sends some osmolytes like sodium through sodium potassium ATPase system and also through organic osmolytes. So the symptoms are not much in chronic hyponatremia. They may stay asymptomatic with 120 to 129. Only abnormality may be a little abnormality of gait. So you should be careful again in rapid correction. Physical examination is very, very important. What we try to find out is the volume status of the patient. We should make out whether the patient is fluid overloaded, the patient has got normal volume, or the patient has got a decreased volume. We should also look for signs of coexisting disease, as we earlier said. Now, what are the bad prognostic factors in this? Somebody has got a hyponatremia, sodium less than 125. Alcoholics, if sodium is less than 105, we know they are also prone for osmotic demyelination syndrome. In acute ST elevation myocardial infarction, it heralds bad prognosis. Cirrhotic patients with persistent ascites, you should correct hyponatremia. In chronic kidney disease, you should identify the cause of hyponatremia, whether it is fluid overload, restrict fluid. Cardiovascular mortality, we know, is related to hyponatremia. Malignancy also, through various mechanisms, result in hyponatremia. So these are all bad prognostic factors. Now, how will you find out the cause of hypotonic hyponatremia? We will have few case illustrations for that. The first step is to calculate the plasma osmolality. The second step is to calculate the urine osmolality. Third is to assess the volume status. Then you estimate the urine sodium and urine potassium. Hope I am audible.
Yes, madam.
Can you hear? It's clear?
Yes, madam.
Okay. Now, when somebody develops hypotonic hyponatremia, it can be due to two mechanisms. One, the kidneys are not able to excrete water normally. This can be due to a reduction in GFR. If the glomeruli is not filtering, if the glomeruli are diseased, it cannot filter water, so the water gets retained. If somebody is taking a thiazide diuretic, there is a decreased water clearance that can result in hypotonic hyponatremia. As we discussed earlier, heart failure, cirrhosis. We should document the volume and find out the patient is hypovolemic. If so, what is the cause of this hypovolemia? Last but not the least, commonly now what we encounter is syndrome of inappropriate antidiuretic hormone. Earlier said as SIADH, now it is called as SIAD. And if so, SIADH is not a disease by itself, it is a manifestation of some serious illness. Whenever there is a retention of water, what the kidney tries to do is it should dilute the urine. So the osmolality will be less than 100. We know that the range of osmolality of the kidney is from 50 to 1200. So if the extracellular fluid contains more water, the kidney should excrete more water. So the osmolality should be as low as 100. It can bring down to 50. So when there is a massive water intake, normally by diluting the urine, the osmolality is maintained. But if you take around 18 liters of water, the kidney is able to excrete only 12 liters. The remaining 6 liters are retained. That can produce hyponatremia. This is what is happening in psychogenic polydipsia. Here, if you measure the urine osmolality, it will be less than 100. As we discussed earlier, if the diet is deficient in protein and solutes, if you are taking more water with low solute, that can also produce a dilute urine. Now, if you measure the urine osmolality after you correct the cause of ADH, it can also produce a low osmolality. There is something called as reset osmostat. As we grow older, after the age of 60 especially, if the thirst center gets stimulated at the osmolality of 275, in the reset osmostat, the thirst center will get stimulated even at the low osmolality of 265. So when the thirst center is stimulated at low osmolality, the person consumes more water, and that will produce a hypotonic environment. Now, let us see, this is a live history of patient which we just had. This is the history of a 60-year-old gentleman who presented with fever, generalized tiredness, slurring of speech, of 1 week duration. So it is not just 1 week, he had a very significant past history. He received a renal allograft as early as 2012. It is almost 12 years now. He had absolutely no problem for the last 12 years. He had a stable GFR of 1.3 milligram, the creatinine of 1.3 milligram. The underlying basic disease for which he got transplanted was a diabetic nephropathy. And his immunosuppressive protocol currently was prednisolone and tacrolimus. Examination, he was euvolemic, he was febrile, pulse rate was normal, he had a systolic hypertension, and there was a pus exuding from the chest wall, which was tested for bacteria and tuberculosis, was negative. So the basic investigations were done. His blood sugar was 79, urea was 28, sodium was 132, potassium was 3.53, and creatinine was 1.3. So the basic abnormality you can make out from this is a mild hyponatremia with a stable GFR calculated to 151 ml per minute. So what is the first step in this? First is, we said, anybody presenting with a low sodium, you have to calculate the plasma osmolality. So what is plasma osmolality? This is a measure of different solutes in plasma. What are the important solutes that contribute to osmolality? Mainly it is sodium. Sodium cannot exist as a cation alone. It is staying with chloride and bicarbonate. Glucose and urea also contributes to osmolality. Though osmolality and osmolarity are interchangeable, osmolality is per kilogram of solvent and osmolarity is per liter of solution. It is just for you to know, but we are using it in an interchangeable way. The osmolarity has to be measured using an osmometer. Those who are appearing for entrance, the method used here is for measuring is a freezing point depression method. Because osmometer is very expensive, we all calculate the osmolality based on the formula 2 into serum sodium plus potassium plus glucose by 18 plus urea by 6. This is the formula used to calculate osmolality. I think we discussed this in the last class. In adults and elderly, the osmolality ranges from 285 to 295. In children, it's slightly on the lower side, 275 to 290. Now, what is the osmolality in this patient? You apply the formula and the calculated osmolality is 272. That is, the patient has a low osmolality, less than 285. So he has hypotonic hyponatremia. What I forgot to mention was this patient presented with fever of 1 week, but why he got admitted to the hospital was he had a gait abnormality and stirring of speech, and the sodium was found to be 132. So the treating consultant thought it could be hyponatremia that is causing the neurological abnormalities. He underwent a detailed nerve conduction study, a detailed neurological evaluation, including a CT, which did not reveal any abnormality. So investigations revealed he had a hypotonic hyponatremia, which is a true hyponatremia. Now, what is the second step? The second step is you have to calculate the urine osmolality. We said that whenever the plasma osmolality is low, that means it contains more water. So the patient has to excrete more water to bring back the ECF osmolality to normal. So if the urine osmolality is less than 100, that means it is patient is secreting more water. So ADH is not the culprit. ADH is not responsible for the retention of water. Understand? If the urine osmolality is more than 100, that means in a situation where the urine osmolality should be less, the urine osmolality is more than 100, that means ADH is retaining more water. This ADH secretion may be for an appropriate stimulus or can be for an inappropriate stimulus. This patient had a urine osmolality of 471, thereby leading to a diagnosis of ADH-mediated hyponatremia. Now, what is the third step? We have to assess the volume. He had no postal hypotension or repeated examination. He had no postal tachycardia or tachycardia. He has normal skin turgor elicited on the anterior abdominal wall. He had a good urine volume of 90 ml per hour. So there is no evidence of hypovolemia either. This patient had no edema, not dyspneic, lung base clear, no hepatomegaly. So there is no evidence of hypovolemia as well. So he is not hypovolemic, he is not hypervolemic. So his volume status is normal. So he has what is known as a euvolemic hyponatremia. Now, what is the next step? When somebody has got a euvolemic hyponatremia, we said the plasma osmolality was low. The urine osmolality, instead of being low, was more. We assessed the volume, it was euvolemic. The fourth step is to measure the urine sodium. If the kidney is normal, when the serum sodium is low, the patient should try to conserve more sodium. That means urine will contain less sodium. So, if less than 25 milligram per liter in a patient with hyponatremia, that means renal conservation of sodium is adequate. More likely cause will be a low effective circulating volume. If more than 25 milligrams per liter in a patient with hyponatremia, that means the renal response is not adequate. The kidney is not either conserving sodium or the kidney is retaining more water. So this could be due to ADH or a salt wasting syndrome. This patient had a urine sodium of 96 milligram per liter, suggestive of SIADH or a salt wasting syndrome. What are the supportive investigations you do for your diagnosis of SIADH? Usually, fractional excretion of sodium. It is more useful to differentiate a volume responsive acute kidney injury from an established kidney injury. It is less useful in the diagnosis of SIADH, but we usually do it even if it is not supportive. We do not consider it as a negative point. So how do you calculate? Urine sodium by serum sodium divided by urine creatinine by serum creatinine. The value here is substituting urine sodium 96, serum sodium 132, urine creatinine 81, serum creatinine 1.3, all in milligram per deciliter. The value is 1.2. If FMAS is more than 2, it is probably supportive, but less than 1 or less than 2 does not exclude SIADH. The reason why this happens is not definitely known. Thereby, FENA more than 2 supports SIADH, but less than 2 does not exclude SIADH. So we go for more reliable parameters like Fe uric acid. More than 10 is specific for SIADH. Less than 8, it is unlikely. The formula again is instead of sodium, you are substituting uric acid. Urine uric acid by serum uric acid divided by urine creatinine by serum creatinine. That is 43 is the urine uric acid. 2.8 is the serum uric acid. 81 is the urine creatinine. 1.3 is the serum creatinine. So 24.65 is the Fe uric acid. That is fractional excretion of uric acid. So it definitely supports SIADH. Similarly, earlier we know that in acute kidney injury also, we used to give a lot of importance of FENA. But later we knew that somebody gives diuretics and you see the patients after exposure to diuretics, this FENA become totally reliable. So people started doing FEUria. The same thing applies for SIADH as well. The formula being the same, instead of sodium and uric acid, you put urine urea by blood urea, divided by urine creatinine by serum creatinine. He had 1160 milligram of urea per deciliter, 28 milligram in the blood, 81 again being the urine creatinine, 1.3 being the serum creatinine. The value is 66.5. Anything more than 55 is SIADH. So he had euvolemic hyponatremia. His urine sodium was more than 25. He had FeUrea of 66.5 and FeUric acid of 24.65, which will support SIADH. Now, though FeUric acid can be a little high in pre-renal also, how you differentiate is you give saline. If the uric acid improves, that means it is not SIADH. If it worsens or remains the same, it supports the diagnosis of SIADH. Now, we have to always think, could it be due to impaired excretion of water? So this patient had a creatinine of 1.3 milligram, though he was a transplant recipient for 12 years. His calculated GFR in DRB formula was 62 ml per minute per 1.73. His only medication was anti-diabetic drugs plus immunosuppression. He was not on a thiazides or salt-losing drugs. So there is no increased excretion of water or impaired excretion of water. There is no defective or decrease in effective circulating volume, which can be a stimulus for ADH. You should remember, earlier we said whenever the ECF is low, the baroreceptors sense this, that sends the signals to the receptors which secrete more ADH, which retains no water. So he has no evidence for cardiac failure. He has no evidence for liver disease. He did not, but for one episode of fever, he never had any infection. He was not on any antipsychotic medications. He did not have any J disturbance. Now, because we could not find any reason, we were puzzled, We were sure that it was SIADH. The patient had some gait abnormality. The neurologist, after an extensive workup, they said there is no cause for SIADH from a logical point of view. EEG is normal, CT brain is normal. Only abnormality they could make out was a nerve conduction velocity abnormality. So, what is common is common. We went ahead and did a CT chest. You can unmute and one of you. Yes? So what this showed was a miliary tuberculosis. This patient had a miliary mottling. We started him on anti-tuberculosis treatment, and because he did not show much of improvement, and for financial reasons, they got discharged and then. So this story tells us he was a transplant recipient doing so well for 10 years. He never had any pulmonary tuberculosis earlier. He had a discharging sinus, which was investigated for tuberculosis earlier, and this time also, which was negative. Because we could not find a neurological reason, we thought could be some malignancy of the lungs, because small cell carcinoma of the lung is notorious to produce ADH. That is why we did the CT test. It showed miliary tuberculosis. So that is how we arrived at. Started with a mild hyponatremia, ended up in miliary tuberculosis. Also, the second presentation. This is a 20-year-old male presented with diarrhea and altered sensorium. Past history was unremarkable. Examination, patient was drowsy. Blood pressure was 80/60, tachycardic, and he had only a central venous pressure 4 millimeters. That means he was hypolimic. He satisfied the criteria for hypolemia. His investigation showed a blood sugar of 108, urea of 60, sodium of 115, and a potassium of 3. That means he had hyponatremia, hypokalemia with hypolemia. So what is the first investigation you do? The first investigation we do is the osmolality. As we said earlier, the osmolality was calculated based on the formula, and it worked out to be 252 milliosmoles per kg. So there is definitely a hypotonic hyponatremia of severe degree because the sodium is less than 120. Okay. Now, the next step is to calculate the urine osmolality, as already said. His urine osmolality was 225, again showing that the urine is not diluted as we expect it to be. That means ADH is acting. Now, what is the stimulus for ADH here? The patient had postural hypotension, tachycardia, and a low CVP. So this patient had a hypovolemic, hypotonic hyponatremia. Next step would be to estimate the urine sodium. So urine sodium was less than 5. That means the kidneys are conserving sodium. So the kidney is not the culprit for wasting sodium. The sodium is lost through some other source. So it's an extrarenal cause for hyponatremia. Check the urine potassium. That was also low. So this patient had diarrhea as a cause of hypokalemia with hypovolemic hyponatremia. What should be the management? You should correct the hypovolemia with renal lactate, because whenever there is a potassium deficit associated with hyponatremia, we should correct the hypokalemia first and then address hyponatremia. Because correction of hypokalemia itself, to a certain extent, will correct the hyponatremia. Now, this is another lady who presented with, you tell me when to stop, okay? You would complete or you want me to stop in between?
No, we will complete, madam.
Okay. This 65-year-old lady with no premorbidities admitted for knee replacement. Pre-op evaluation showed a blood sugar of 84, urea of 19, creatinine of 0.4, that means diluted, sodium of 123, that is moderate hyponatremia, potassium 4.08, chloride normal. So she was referred for management of asymptomatic moderate hyponatremia. The patient had not received any hypotonic solution like half normal saline or 5% dextrose. The patient was not on any diuretic or other medications to explain hyponatremia. So this patient had hypotonic, euvolemic hyponatremia. So as we discussed, you should estimate the urine osmolality, and the urine osmolality is more than 100, you should check the urine sodium. So this patient had a urine osmolality of 341, thereby suggesting it is ADH mediated. Assess volume. The patient had no evidence of hypovolemia or fluid retention. So this is a euvolemic ADH mediated hyponatremia. Urine sodium was measured, which showed 40, which is more than 25. That means the kidney is not conserving sodium, though it is excreted in less water. That means ADH is acting. Uric acid fractional excretion of 15.54, which supports SAADH. Here, what is the reason for SAADH? You know, severe pain itself can produce ADH, and that is a well-known cause for inappropriate ADH stimulation. That had resulted in hyponatremia in this patient. Now, we have discussed two patients with euvolemic hyponatremia and one patient with a hypovolemic hyponatremia. One had severe hyponatremia with sodium of 115. The other had a sodium above, other two had sodium above 20. Now, what are the general treatment guidelines for treatment? You should identify and treat the underlying cause whenever possible. If it is a severe hyponatremia, you can't waste time on identifying the cause and treat. You have to address the hyponatremia. But if it is an asymptomatic mild hyponatremia, you should try to figure out what is the cause and reverse the cause. If the patient is on thiazides, try to discontinue thiazide. If the patient is on NSAIDs, try to stop NSAIDs and repeat the sodium and C. If the patient is obviously hypovolemic, correct the hypovolemia. There are certain definite guidelines which we'll soon see for correction of sodium deficit. You have to reduce electrolyte-free water intake in SAADH. Impose fluid restrictions in fluid overload and euvolemia. You know, in cardiac failure, severe renal failure, fluid overload dilutes the sodium. That is responsible for the hyponatremia. which we call as a dilutional hyponatremia. The answer here is not to give sodium. You restrict your water intake, so that will bring back the sodium to normal. What are the goals of therapy? The goals of therapy are, you have to treat the symptoms of hyponatremia. First and foremost, you should protect the brain from cerebral edema and herniation. If there are neurological symptoms due to hyponatremia, correct hyponatremia and see the neurological symptoms resolved. You should find out why the sodium is falling. So take steps to prevent further decline in sodium. At the same time, you should be very judicious in your management that you don't want the patient to develop osmotic demyelination syndrome, which is irreversible. What are the risk factors for decrease in sodium? When a patient has low sodium, the patient by mistake takes more water. That can further dilute the sodium, increase the hyponatremia. There are marathon runners who take a lot of water in between. They are not giving, so they drink a lot of water. So they develop hyponatremia. Psychogenic polydipsia. Users of drugs, because of less solute intake, they also develop hyponatremia. Delays absorption of digested water from the gastrointestinal tract. Parenteral fluid and the wrong parenteral fluids, like 5% exhaust, half normal saline in a patient with hyponatremia. In surgery, severe pain or the postoperative state itself can produce ADH and result in hyponatremia. There is a condition called desalination. That is, if you correct the hypovolemia with large volumes of isotonic fluid, there will be a volume expansion. The kidney will sense that there is more sodium coming in. So that itself will be a cause for increased sodium excretion in the urine. This is called as a desalination. If the antidiuretic hormone level is high, that will retain more water. So sodium will be excreted in a concentrated environment that can also produce hyponatremia. Now, what is the first line management? We have discussed 2 cases of SIADH. What is the first line therapy? We emphasize the role of fluid restriction. The simple dictum is measure 25 urine output. That should be, the fluid intake should be 25 urine output minus 500. How will you decide whether fluid restriction alone is sufficient? You should measure urine sodium, urine potassium. You have measured all this for the urine osmolality. That should be divided by the corresponding serum sodium. If the urine sodium plus potassium by serum sodium is less than 0.5, that means if you restrict fluid alone, that will bring back the sodium to normal. If it is more than 1, that means fluid restriction is not sufficient. Indications of pharmacologic treatment are, if the patient's urinary parameters indicate low renal electrolyte-free water excretion, or if the serum sodium does not rise after 24 to 48 hours of fluid restriction, we have to use agents like salt supplements, vaptans, tolvaptan and conivaptan. Urea, which we don't use, we are commonly using salt and vaptans. The patient in question has a urine sodium of 40, potassium of 48, for a corresponding sodium of 123. This brings us to a ratio of 0.7. So this is neither less than 0.5 nor more than 1. So we gave this patient a little fluid restriction and also supplemented salt. We tend to use more and more of tolvaptan without knowing what we are doing. Some people even use vaptans for aggressive correction of hyponatremia, which should never be done. Vaptans act by blocking the V2 receptor antagonist, by blocking the aquaporin 2 channels. So it takes time. So it increases the excretion of solute, but water is not retained. More water is lost in the urine. That is how the sodium goes up. The dose of tolvaptan currently used is 15 milligram once daily. You should, because the well-known toxicity of tolvaptan is hepatotoxicity. So you have to monitor SDPT periodically. Can anybody put in the chat box what is the other indication for Vaptan from nephrology point of view? We use Vaptans for polycystic kidney disease, autosomal dominant polycystic kidney disease. It is supposed to reduce the size of the cyst, and if you use Vaptans carefully monitoring liver, then it is shown to be of definite use in this decreasing the progression. So it should be used with caution in CLD, because already is a liver disease. You are going to exhibit a drug which can further aggravate the liver damage. So you should be very careful in monitoring the liver enzymes. So what are the indications and contraindications of Vaptans? It is indicated only in euvolemic hyponatremia. It should not be used in hypovolemic or hypervolemic hyponatremia. It should not be used concomitantly with 3% saline. In a patient who is admitted in CCU, if the patient has got a sodium of 115, don't give 3% saline. Along with that, don't combine Vaptan. It is not indicated in the emergency management of hyponatremia. Only 3% saline will come to your rescue in the aggressive correction. Never use Vaptan in hypovolemic hyponatremia. Now let us see the fourth patient we had. This is a story of a 50-year-old lady with history of hypertension and hydrochlorothiazide. She got admitted with alteration of sensorium. The only significant recent history was she was taking metalazone recently. On examination, her blood pressure was 110/70 with a postural fall of 90/60 in the sitting posture. She was tachycardic. She had diminished skin turgor. She was weighing 60 kg and she was oliguric. Her blood sugar was 90, urea was 60, sodium was 118, potassium was 3.1. So what she had a hypotonic hyponatremia with hypovolemia. So let us see what are the indications when somebody has to be admitted for management. As this lady, there is an alteration of sensorium and low sodium. Hospitalized treatment should be instituted. So acute hyponatremia. If the patient has got severe symptoms, even if the sodium is more than 120, we have to admit. Symptomatic hyponatremia, neurological symptoms, you have to admit. What should be the first line of the management in this lady? You have to withdraw metalazone and thiazide. Wait for some time to see whether the sodium goes up. Because she is already hypovolemic, you have to correct the volume. Then comes the correction of hyponatremia. Now, how will you correct hyponatremia? There are different guidelines. In an asymptomatic acute hyponatremia, the correction can be 50 ml bolus of 3% saline over 10 minutes. I don't use it. That is what is recommended. It is used if after correcting the volume, if the sodium does not go above 130, you can exhibit 50 ml bolus of 3% saline. How will you correct autocorrection? What do you mean by autocorrection? If you correct only volume, the sodium goes up from 115 to 125. That means the sodium gets corrected by itself. In this situation, if you give 3% saline, the sodium will dangerously go up. So you have to see whether the sodium is getting auto-corrected by correction of hypovolemia. So how will you monitor for autocorrection? The specific gravity should be less than 1.005, which is always given in a urinalysis. You have to measure the urine cation, that is sodium plus potassium. It should be less than 1/2 of the serum sodium value. Or you measure the sodium and make sure the sodium is gone up. Now, if the patient is symptomatic or if you want to correct hyponatremia, you should definitely go by the guideline, because you can increase the serum sodium only by 4 to 6 milliequivalents, you know. This can be achieved either by 100 ml of 3% saline. This can be repeated for 2 additional doses, that is of total of 300 ml over a period of 30 minutes. Or you can use 2 boluses. Instead of 3 into 100, you can make it 2 into 150, but the maximum can be only 300 over 30 minutes. Whenever there is a sodium correction happening, you have to take into consideration 3 components. It should be the deficit correction, because you want the sodium 115 to go up to normal. That is only you are correcting the deficit. But you and me require a regular requirement of sodium. No? That is 1 milliequivalent per kg. And this patient is also losing sodium in the urine. So you have to correct that also. So whenever you try to correct sodium in hyponatremia, you have to take into correction the deficit correction, the maintenance requirement, and the ongoing loss. So how will you correct sodium deficit? It is total body water into normal sodium minus patient sodium. So this patient is weighing 60 kg. So 60 kg adult, the total body water is 60 into 60%. That is 36 liters. Patient sodium is 118. So in 1 liter, the patient has got a deficit of 22 milliequivalents. So the total deficit will be 1 liter is 22. So in 36 liters, it is 36 into 22. That is 792. That much of sodium is required for correcting the deficit. The maintenance requirement is 1 milliequivalent per kg. So the patient needs around 60 milliequivalents for that, because the patient is weighing 60 kg. Urinary loss is 25 milliequivalents per liter, and the volume is 1200 ml. So 25 into 1.2 gives you 30. So the total sodium requirement is 792 plus 60 plus 30, 882. That is, whenever you correct the requirement of sodium in a hypovolemic hyponatremia or with hypotonicity, you have to take into consideration 3 factors. You have to correct the deficit, which should be slow. You have to give the maintenance requirement. You have to also replace the sodium that is lost in the urine. So how will you calculate the volume that is needed? We know that 1 liter of normal saline contains 154 milliequivalents of sodium. So if you want to provide 882 milliequivalents, it should be around 5.72 liters. To bring back the sodium to normal of 130, the patient requires 5.72 liters. If you use 3% saline instead, supposing the patient has got a borderline hypovolemia, if you give this much of saline, 5.72, the patient might go in for pulmonary edema. In that situation, it is better to use a concentrated saline, like 3% saline, which contains 513 milliequivalents of sodium. So to give 882 milliequivalents, you require only 1.7 liters. Now, we also know that we can't bring back the sodium from 115 to 130 aggressively. We can only correct from 115 to 120, maximum 115 to 123, not more than that. We usually go only to 6 milliequivalents. No, it is not the rate of change, you know. It is not in 4 hours, 6 hours. It is the change that is occurring in 24 hours that is important. Meaning, in 24 hours, you cannot bring up the sodium faster than 6 milliequivalents per liter. So how do you find out this? How do you know how much sodium will go up if you give 1 liter of normal saline? Again, there are formulae. You can leisurely go through all this, and if you are not able to understand, you can come back to me or can discuss with me. I'll be free for discussion anytime. I know this is a complicated topic, but then there is no choice. We have to learn only. Rate of rise of sodium is given by this formula. Sodium in the infusate minus patient sodium by total body water plus 1. That is infusate. If you are using normal saline, which contains 154 milliequivalents of sodium chloride, if you give 1 liter of saline infusion in a patient who has got 118 milliequivalents per liter, and if I'm sorry, it is 36 liters, not 42, 36 liters, the rate of rise will be saline contains 154, normal saline. Patient sodium is 118. Patient's body water is 36. To that, you are adding 1 liter, so that is 37. The sodium would go up by 0.97 milliequivalents per liter. So we know that the patient can go only up to 5 milliequivalents, maximum 6 milliequivalents per liter. So we can find out how much of normal saline can be given in a patient with hypovolemia. If the same patient receives 3% saline, it will be 513 minus 118 divided by 37. So the sodium would go up by 10.6 milliequivalents. So you should be very careful in giving 3% saline, because even 100 ml of 3% saline will elevate the sodium by 1 milliequivalents. So if you give 500 ml saline, 3% saline, that will bring up the sodium by 5. So if you aggressively give more saline, they can result in ODS. If potassium containing fluids are used, the main potassium containing fluid used is ringer lactate. So sodium plus potassium in the infusate minus patient sodium by total body water plus 1. So in the same patient, if you are giving a ringer lactate contains 130 sodium, 4 potassium. So that will elevate the sodium by 0.43 milliequivalents. So this is the rough formula. Normal saline 1 liter per hour, 3% saline 100 ml per hour. The rough formula is 1 ml per kg of 3% saline will elevate the sodium by 1 milliequivalent. That is, in a 50 kg man, 50 ml of 3% saline will be required to elevate the sodium by 1 milliequivalents. So if you want to go up by 5 milliequivalents per liter, you can use 50 into 5, that is 250 milliequivalents. So that is how you correct. So in chronic hyponatremia, the recommendation is you have to correct very slowly because the brain autocorrects. In patients who are highly vulnerable for ODS, it should be not 6, it should be 8 to 12 milliequivalent in 24-hour period. You should be very careful in correction. Briefly, we will see what is the complication of treatment. Overcorrection is more dangerous than undercorrection. Osmotic demyelination is irreversible. Fatal complication of overzealous sodium correction can result in this dangerous complication. The risk factors being alcoholics, malnourished, thiazide-induced hyponatremia, liver disease, and hypokalemia is definitely a cause for ODS if you aggressively correct the hyponatremia. Again, the symptoms can be dysarthria, dysphagia, paraparesis, quadriparesis, altered behavior, seizures, coma. We can diagnose by MRI brain. Earlier, this was called as central pontine myelinolysis. Now we know it affects not only pons, it affects medulla everywhere. So it is renamed as osmotic demyelination syndrome. The best management is prevention. But if you somehow overshoot and the next sodium comes as elevation by 8 milliequivalents or 10 milliequivalents, immediately what you can do is you can stop and give free water. That is 5% dextrose. That will bring down sodium rapidly. So best thing is to prevent, but somehow you overshoot. And if the sodium goes up from 118 to 128, don't wait for the symptoms to happen. You can give 5% dextrose and try to bring down the sodium. So let us skip this. These three you can go through later. This is the algorithm to follow. If somebody has got hyponatremia, I think this will be in the YouTube. You can always go through. So in the last few minutes, I was trying to tell you the importance of hypotonic hyponatremia How do you correct hypotonic hyponatremia? The approach should be measuring plasma osmolality, measuring urine osmolality. If not, calculate plasma osmolality, calculate urine osmolality, assess extracellular fluid volume, estimate urine sodium, estimate urine potassium. If you arrive at a diagnosis of SIADH, before saying it is SIADH, exclude other causes that can stimulate ADH release. All the same, you should also exclude Addison's disease by a cortisol estimation and hypothyroidism by a TSH estimation. And if you are sure that is SIADH, the management should be fluid restriction. What fluid, how much you restrict fluid? 25 urine output minus 500. How do you find out fluid restriction alone is sufficient? You estimate urine sodium plus potassium, divide by serum sodium. Less than 0.5, it is fluid alone. If it is more than 1, you have to exhibit some other therapy. We also should understand and convince ourselves that Vaptans are not for emergency management of hyponatremia. It should not be used in hypovolemic hyponatremia. It should not be used in hypervolemic hyponatremia. It can be of use only in a chronic hyponatremia due to SIADH. Vaptans are not very safe drugs. You should carefully monitor liver enzymes. Though it is used also in liver disease when a patient has got cirrhosis with hyponatremia, the gastroenterologists very often use Vaptan, but they carefully monitor SGPT before they do that, because any elevation of SGPT, they withdraw Vaptans. Vaptan should never be combined with 3% saline. It is not emergency management. You can all the same give calculated salt also. Now you have salt capsules available. 1 gram salt, if you give, you can calculate how much gram salt is required. You can give that much of grams of salt in less water. So that itself can correct the euvolemic hyponatremia. So I think that will finish this class on or discussion on, though I was not able to discuss because of the internet issues. That will finish the discussion on hyponatremia.